Well, if we can't use symptoms to point to kidney diseases reliably, what can we use? Here's the quick summary. There's blood pressure and fluid balance. There's blood in the urine. There's protein in the urine. Of course, there are some other symptoms too. People typically expect alterations in urine volume to be very helpful, but interestingly, that's rarely the case. You'll be familiar with the characteristic causes of polyuria, sometimes osmotic, sometimes loss of hormonal control, and sometimes there are kidney diseases that lead to excessive sodium loss or, as an early sign, just loss of diurnal rhythm causing nocturia. But mostly the amount of urine you produce is related to how much you drink. So out there in the general world, there's a huge variation in that. Some people will drink 5 or 6 litres a day even. Others, you'll be lucky if they drink a litre. Normal, of course, is enough to excrete the solutes that you have to excrete for health, and that's probably around 500 mils a minute. So typically we call oliguria in an inpatient where we're worrying about acute kidney injury something below 300 mils a day or 500 mils a day. Just an interesting point, complete anuria, complete absence of urine production at all, is very unusual. It really implies that there's a problem emptying the bladder or that there's complete loss of circulation to the kidney. But of those two, obstruction is much the more common explanation. Then there's alterations in what the urine looks like or occasionally smells. And of course, you'll know most of the issues around this. Red, obviously blood. Brown can be because of myoglobin in the urine, but drugs can cause almost any colour you like at all. Frothy urine is characteristically caused by the presence of protein. Otherwise, that can only be picked up reliably by dipstick testing. Now, hematuria, and every textbook has a diagram something like this, can come from any level in the urinary tract. So it can come from disorders causing infarction of the kidney, it can come from cysts, it can come from tumours, vascular malformations, inflammation within the kidney, but most commonly it comes from infection and, very importantly, from cancer in the kidney itself, but typically in the lower urinary tract, the bladder and sometimes the ureters. Of course, there are some things that make the urine a different colour or red without being blood, and don't forget the alarming consequences of eating beetroot. Clotting disorders is on this list, but actually you shouldn't bleed from your urinary tract, even if you've got a very high INR due to too much warfarin, too much anticoagulation. You really need to have a bleeding source as well. And don't forget to repeat the testing if the blood in the urine could be due to menstruation or just vigorous exercise. Testing urine after people have run a marathon is quite a frightening thing to do. Not recommended. Should clear within a day or two. Urine microscopy can help, of course. It can show cells, bacteria, casts, and so on. This is a picture of white blood cells in the urine, typically associated with urinary tract infection, and you can probably see some microorganisms in here too. These are neutrophils, suggestive of acute infection. Of course, you can occasionally get white cells in the urine from more unusual infections like tuberculosis, or from white cells being in the kidney itself because of inflammation. It's over 100 years since the implications of red cells in the urine were realized. If they form into these cast shapes associated with protein in proteinaceous deposits coming from a tubule and reflecting a cast of that tubule, here shown in cross-section, it implies that the red cells have come from the glomerulus. That's incredibly useful information because red cells can come from any level in the urinary tract. There is another way of telling apart cells that have broken through the glomerular basement membrane in the glomerulus from cells that have just come from another point in the urinary tract. And it's the variation in morphology that you can see here on the right. Some of these poikilocytes, little droplet formations coming out of the side of these cells are supposed to be particularly characteristic of cells that have squeezed through the glomerular basement membrane. Unfortunately, we don't do this test routinely. It's pretty much a specialist laboratory technique. You need fresh urine and to look at it under a good phase contrast microscope. On the left-hand side is shown the more typical evenly shaped red cells that you'd see in the urine from a lower urinary tract lesion. Occasionally you can also see more unusual and still very helpful things. Urinary crystals were characteristically associated with the early antibiotics, the sulfonamides, which could crystallize in the urine and cause acute renal failure. We still get that nowadays with acyclovir, the antiviral drug, and with some of the protease inhibitors used for HIV treatment, and a few others as well. Proteinuria is a much easier thing to interpret because it almost always comes from the kidney itself. This slide just quickly summarizes that albumin is almost completely excluded from the urine at the glomerulus, and the small amounts that do filter through are reabsorbed in the proximal tubule. The protein that you see in small amounts in urine normally is TAM horsefowle protein, which is secreted in the tubule, possibly to reduce stone formation or infection. If you see albumin appearing in the urine, it implies that there's something wrong with your glomerular filtration barrier. You've got a glomerular problem. If you see low molecular weight proteins in the urine, it may be because the proteins that are normally filtered at the glomerulus would normally be reabsorbed in the proximal tubule are leaking through into the filtrate and remaining in the urine when it gets to the bladder. You can get up to 150 milligrams a day of that, much more than that, and you begin to think that there must be an explanation for it. Blood tests for kidney function are often what we rely on to diagnose renal impairment. Traditionally, urea was the thing that was used. Incredibly useful, but not a very reliable marker of kidney function because it's affected by what you eat and how dehydrated you are. Creatinine has proved a much more useful guide because it's produced at a fairly constant rate by muscle. The thing is, we have very different amounts of muscle as individuals, and therefore it really needs to be normalized for your age and body size. There are various equations around for doing that, and the one that's usually reported on blood tests is this 4-variable modification of diet in renal disease study equation, which is shown below. There's a newer one, the CKD-EPI equation, which is probably more accurate at higher GFRs, so more accurate near normal, and that's maybe coming more into use in the future. These are useful because if you just use creatinine itself, you'll see that as your GFR drops, you don't see very much rise until you're well below 50% of a normal GFR, particularly in women. However, all of these tests have problems, all of these estimations of GFR. First of all, they're only an estimate, and they're particularly inaccurate at levels near normal kidney function. So there's a risk of categorizing healthy people as having renal impairment. Secondly, there's a lot of variation in people's muscle mass, and some relative differences between different races have been spotted. There are adjustments for a number of races, but the one that comes up in most commonly is the 20% difference between Afro-Caribbean origin people living in the Western world, so in the UK or the USA. You should add 21% to their estimated GFR when using the MDRD method. For other races, it's not so clear. And indeed, if you go to Africa, it's not so clear there either. But it's really important to note who eGFR estimates are not for. It's not for people with an acute illness, when creatinine may be changing quite quickly and there may be issues with nourishment and muscle wasting. It's not for changing values. It assumes that you have a stable creatinine. It's not for children, and it's not accurate in pregnancy. And of course, if you have other causes of having low muscle mass, then it's not going to work there either.